This
value-based
conference
care,
will now be recorded.
we really have a strong opportunity to leverage the systems and processes and tools and the contracts that we take as a community and be able to use the information and the systems and the processes to best respond in the time of the pandemic right now with the coronavirus. So we have a agenda that's broken down into several different pieces. One is staying connected and informed. We feel like there's so much information coming out at you. We want to have one area in our website that you can refer to that keeps it current. And every time something new comes in, we're updating that. Dr. Van Fleet Green is going to lead us through some conversation on COVID background and the current state. We have reached out and heard from many of you on PPE needs, and we want to provide supply support where we can in aggregating data or aggregating supplies and distributing that accordingly. And then we're going to talk about how we're using data to prioritize patient outreach and manage social determinants of health and care management. We're keeping a lot of our chronic condition patients at home, and we want to make sure that we have systems and processes to help support them at home where they should be and not a burden to the hospital system, as well as providing risk to themselves and to health caregivers as they prepare for the surge. And lastly is that there's a lot of advocacy and public policy updates that I'm going to share with you, as well as some of the focuses, because as many of you are independent providers, I think cash flow is going to be an issue with shutting down ambulatory surgery centers, primary care is having much reduced visits. I know from a hospital side, they're seeing 60% reduction in ER use. So there's a lot of systems that their volumes have drastically reduced based in response to the COVID and the social distancing and so forth. So we want to make sure that we're keeping some of the business sustainability considerations also in top level. So I'm going to ask whoever joined just to mute because we have some feedback. Okay, great. So we're going to talk about the communications for providers, and I'm going to pass it over to Nikki, who's going to share some of that information with us.
All right, good evening, everyone. This webinar is going to host a ton of information, and we're going to go pretty quick on this. So I wanted to share with you two sources that will keep us connected. If you haven't already, I encourage you to go to the PSW provider portal, which the information is right there at the top, and the password is PSW 2019. All the information from this webinar will be posted on the portal if it's not already, so make sure you keep that in your back pocket. Secondly, we have started a Facebook private group called PSW Provider Network. We encourage all staff to hop on this discussion in Facebook so we can share ideas, questions, support each other, and really it's just an open forum for everyone to stay connected. Throughout this webinar too, you'll see blurbs on certain screens where if there's too much information on a slide, it's on the portal for reference.
Great. The other piece that I wanted to make sure that we have is a strong link and visibility for you under some of the resources. So there's the business workers webinar and link that's going to talk about how you can help engage with your employees and workers and loan assistance, as well as taxpayer relief. So we have some scenarios and benefits that are posted on the website. There's also a webinar that's going to occur this week for the Thurston County businesses at 2 o'clock, and we're going to send the link for that. And the topics that they're going to share is resources for recovery after COVID-19 and some of the loan and employment resources. So we want to make sure that you have the opportunity to attend that, because some of that information may be relevant for you as you help with your practices. And each practice is very unique and different in terms of how they're going to finance. So we didn't want to spend too much time in detail on the nuances of each program, but I do want to encourage you to reach out to us in any way that we can help connect you to the right resources. It's very important that you're able to sustain your business continuity through this tremendous unprecedented revenue strain. So, okay, great. I'm going to turn it over to Jessica, who's going to talk to us about the COVID background and current state. So, Dr. Van Fleet Green.
Great, thank you. You can go ahead and progress to the next slide. So I have spoken with many of you, probably half the people on this webinar in the last 3 to 4 weeks, and I want to try and strike the right balance for covering the clinical information and what's relevant to all your practices, Certainly, if you have any questions, you can hit the speech bubble at the top. Those will pop in, and I can try and get those answered or try and find the right answer. Or for those of you who have my numbers, you can text me. My cell phones are sitting right here. But I wanted to briefly go through just the state timeline. If most of you are like me, it feels like we've been at this for about a year already, but it turns out it's only been a little less than a month since the first positive case. So I think that this is helpful, this context and perspective, particularly when we're talking about with our patients and our families. So January 15th is when patient 0 returned from Wuhan, China. And on the 17th of January, 2 days after that individual arrived, is when the U.S. began screening passengers coming into airports. January 19th is when patient 0 presented to an urgent care clinic. Of course, the patient knew that they were coming from Wuhan, knew that they were at risk for coronavirus. They put on all appropriate PPE prior to entering the urgent care facility, and they were tested. And unlike the current state that we are in today, they actually had test results back within 24 hours, and the patient tested positive. The patient then was transferred to the Providence Everett, and the reason why they were transferred there is because Prov Everett is where, as many of you know, they had the biocontainment ward for Ebola. So the patient was actually in an Ebola biocontainment ward. He was not being seen directly with hands-on. Everything was being done through the very controlled biocontainment process. And by the 21st of February, the patient fully recovered and was able to be discharged. It was identified through the course of that the patient had 60 contacts. And so we now think that potentially there was 61 and that one of them were missed. The other possibility that I know you guys are all aware of is that there was another person who had come in that was not identified. But within that, February 19th, there started becoming several patients ill at the Life Care of Kirkland facility that we are all now well aware of. And they had multiple respiratory illnesses. And in contrast to what the media has portrayed in the last several days, the facility actually did a very good job of isolating patients per standard protocols in skilled nursing facilities. In the meantime, their medical director and several of their staff also got sick and had to be isolated. And ultimately, the patient crumped several days later and had to be transferred to the hospital. Not recognized immediately that the patient was possibly positive for COVID. It actually took several more days before the patient was identified as a positive on the 28th of February, which was a Friday. On that same day, a second case in the state was identified, which is a teenager who did not live far away from patient 0. So again, just sort of helpful background and context on that timeline of kind of how we got to where we're at, and then the 29th, the first patient death. So I wanted to go over kind of the basics again, sort of helpful when you're talking with patients and educating. So viability on plastics, about 72 hours, viability on stainless steel, 48 hours, viability on cardboard, 24 hours, and viability on copper, about 4. I'm going to pause there and ask whoever just joined if you could just go ahead and mute yourself because we're getting a little bit of background noise. Just want to make sure everybody can hear. Thank you. So again, helpful that we really recognize that fomites can be a major driver in how this is spread. So really emphasizing surface cleaning, whether you're in your clinic, in your home, or encouraging education with your patients, that the surface cleaning is exceedingly important. To date, there are no studies on heat or cold stability. I know that there was a lot of talk in the beginning that this may go away with warmer months, but we still don't have any data on that. We do have some data on the R0, and for those of us who haven't been in a microbiology lab in a while, as a reminder, the R0 is essentially just how contagious the virus is. So the R0 is 2.5. There are estimates that it's somewhere about 1.5 to 2.5, but the most recent data out of a microbiology lab, I believe out of Hopkins, was that it was 2 to 2.5. That is in comparison to influenza. So sort of translating that into everyday language, if I get influenza, I am likely to give it to 1.3 other people. So 1.5 people in my household are going to get sick from it. If I get COVID tomorrow, then 2.5 people are going to get it. So again, recognizing that this is likely more contagious than influenza, it is also about 10 times more virulent. Again, real-time language, about 10 times more deadly. So we also believe, similar to influenza, that patients are shedding virus about 24 to 48 hours prior to showing symptoms. So this is sort of the media attention around asymptomatic carriers. What the WHO says is that they do not feel like this is a major driver of spread, which actually seems fairly surprising. They actually feel like a bigger driver of spread is those who don't know that they're positive, of course, which is why data is compelling on those countries that have more tests available are actually doing better. Because if you know you're positive, then you're more likely to quarantine, because for most of us, this is very mild and we don't know that we're walking around with it. And again, I've already mentioned that fomites. And then again, 80% of cases are very mild. For every dozen cases diagnosed in the U.S., we think there's about another 20 to 25 that are missed, again, emphasizing the need for testing. Infection cases are doubling about every 6 days, though refreshingly, coming out of Pierce and Thurston County in the last week, we have actually not observed that. Again, is this lack of testing, or are we actually flattening the curve? And so we're hoping clearly it's the latter. And then we also know that about every 20 to 30 days, a minor mutation is occurring. So typical for other viruses and zoonotic diseases. You can go ahead and progress to the next slide. So I think that this is an important slide for those of us who are working on the front lines. So this is data out of Evergreen. And so 65 to 80% of people have a cough. It is described by most people as a dry cough. Only about 45% of patients are febrile on presentation. So I think that that's really important to highlight, because I know that there are very strict guidelines for testing right now because we don't have a lot of tests. But it's recognizing that almost 60% of patients aren't going to have a fever when they first get this illness. Throughout the illness, they will develop a fever about 85% of the time, but it doesn't happen for everyone. I also think it's important to note that the fevers are actually more mild, particularly in elders, than originally reported. And so those subjective fevers that patients report are actually very meaningful. So I was lamenting with one of my colleagues earlier today, and how it just used to drive us nuts in clinic, where patients would come in and they say, well, I have a fever, and like, well, it's only 99. They're like, yeah, but I always run low. This is actually one of those cases where I think that's a valuable teaching moment for us, because a 2-degree rise in baseline is actually very meaningful. You know, I'm checking my temperature twice daily right now, and I'm running at 97.6 to 98. If I suddenly jump to 99.6, I'm going to be worried. That's going to be a fever for me, and it's going to be worrisome for a febrile illness. So kind of, you know, getting back to those elders that always say that, I think is a good lesson here to be learned with that, that they will potentially present differently, and it's important to recognize. 20 to 40% of patients are going to get dyspneic. About 10% of patients will actually get some GI symptoms, and then 15% will just kind of have runny nose, cough. We've actually had multiple employees who have called me with mild symptoms and say, hey, I think I just have a spring virus, or maybe I just have allergies, I have a runny nose, I have a cough, I have a sore throat. Well, the spring virus this year is COVID. So assume you have it if you don't have testing, and in young, healthy people, it could just be a mild URI. So for those sicker patients who are presenting to the emergency room and to the hospital, it's not predictable whether they get leukocytosis or leukopenia, but it is fairly consistent that 80% of patients have lymphopenia. So whether high or low, you're going to see those low lymphocytes. So important to pay attention to. Additionally, we're seeing rises in AST, ALT, and T-bili. Procalcitonin, not super helpful, can be high or low. And then the chest x-rays, we're getting bilateral ground glass appearance. Very rarely is this presenting with a unilateral appearance on chest x-ray. It's interesting, I was also talking with another colleague maybe yesterday, and we've seen more and more radiology reads in the past couple of weeks kind of making the call on diagnosis when they're seeing those bilateral ground glass opacities, where radiology colleagues are saying cannot rule out COVID. So I think that's important to note. I also think it's clearly important to note to put your clinical history in there. Like in the patient that it happened to me on, the patient had interstitial lung disease, and the chest x-ray was very consistent with what he always looked like. So it, you know, puts us in a little bit of bind for testing. So making sure that you note that when you're ordering chest x-rays on patients that you aren't concerned about. Go ahead and progress to the next slide. So I wanted to make sure and note the treatment options, not that we would be treating anybody in the outpatient setting, because I definitely would not recommend that, and that's certainly not what the recommendations are at this point. But if patients are getting hospitalized, then there are some NIH adaptive randomized control trials going on with remdesivir, chloroquine, hydroxychloroquine, and azithromycin. So I think what's important for all of us to know in the outpatient setting is that we are going to see critical drug shortages of this. We have already seen physicians stockpiling this. We are seeing patients trying to get 90-day supply. And so we are actually having to put some rations on that, and pharmacies are having to ration what they are supplying. I know that for me personally, I did try and secure extra supply and PAR levels in my Pyxis of azithromycin, since I do use this so frequently in my elders. So I think it's important to note that you guys could be seeing that in the outpatient setting if you are prescribing azithromycin for just a community-acquired pneumonia, which is still a recommended drug as part of that algorithm. So, so again, just important to note critical shortages. Go ahead and go to the next slide. I also wanted to mention the issue of ibuprofen. So I know initially the WHO came out and said, we don't recommend this. They then redacted their statement. That, of course, came out of the Lancet, where they identified that ibuprofen boosts ACE2 receptors. So there's, of course, a theoretical risk that the virus can spread faster if you boost the ACE2 receptors, because, of course, that's what the virus binds to. The British Medical Journal then reported outcomes in France. They concurred with this from the what they observed clinically, is that patients who were getting anti-inflammatories, so it's not just ibuprofen, but any NSAID that works on ACE2 and COX, that they did not fare as well. But despite that, the WHO did come out and say that at this point, they do not advise against ibuprofen. Again, what I've been speaking with my colleagues about, and what I've been telling patients and families or employees that call, there's a really good alternative in acetaminophen. And so my preference, my clinical decision making at this point is recommending that people use Tylenol instead. So that's clearly not evidence-based at this point. WHO is still recommending that go ahead and be used. So, Dr. Jesky, thank you. So just commented, remember that viral conjunctivitis is also a presenting symptom, and that coronavirus has also been identified in here. So thank you for that comment. Appreciate that. Very good point that we are seeing, much like other viral illnesses, seeing the conjunctivitis that goes along with it. So additionally, theoretical risk with the ACE-ARBs. Sorry, can you go back to that last slide, please? The ACE-ARBs and hydrochlorothiazide, also because of ACE2 receptors. Again, most patients that are hospitalized are pretty hypotensive and sick, so those are probably going to be held anyway. Also, they're seeing a rise in BUN and creatinine. And then there is anecdotal evidence that those patients receiving corticosteroids did not do as well. So unless you're treating a secondary illness, or they really absolutely have to be on a steroid for COPD in conjunction with COVID, that's something that you probably want to try and avoid. Okay, now we can go to the next slide. So this was just a reminder for those of us on the Washington State Medical Association. This was put out, I believe, on Monday or potentially Friday, after the data came out about azithromycin and Plaquenil, that they saw stockpiling. And so just remember appropriate prescribing. Don't stockpile. Don't prescribe to yourself and to your family members. So yeah, this is a sort of public service announcement and a reminder on that front. So you can go ahead and progress to the next slide. And I'm not going to go into too much detail, but I will just highlight here that for testing, the first week of February is when CDC sent out test kits. As we all know, those test kits did not work. Second week of February is when that was identified. The third week of February, the guidelines then shifted on who to get tested. It got much more restrictive, recognizing that we didn't have enough tests. Also in that time period is when the University of Washington, shortly thereafter, actually started rolling out more tests. Third week of March, so last week, they started disseminating more tests. Of course, I think all of us have been frustrated that those tests are still taking 3 to 7 days, partly because the University of Washington lab has such backup. I will tell you that I was on a call today. We thought that there was going to be a little bit more relief with the FEMA tests, particularly in Western Washington. So I was on a public health call today, and unfortunately, FEMA will not release those tests to post-acute and long-term care facilities or private clinics. The tests are only going to be released for those who are setting up mass testing sites. So I think that that's important to note. It was certainly a disappointment that many of us shared on the call. I will also note that we thought that there was going to be some reprieve coming with PPE. I'll save that for later in the presentation. I believe Carrie Wetzel is going to speak with PPE resources, but a lot of the PPE has been diverted to New York because their curve is looking so much steeper than ours. So we kind of got moved lower down on that priority list. So I think important to note that right now, current state, don't expect PPE or testing to really change. So I think we still need to operate with a lot of rations. We still need to plan to reuse things. And I think that getting used to operating in the way with which we've been operating the past couple of weeks is the way it's going to be for a while. So here's just those stats globally. So over 450,000 cases, we've now up to 65,000 cases in the U.S., 123 deaths here in the state of Washington with a little over 2,400 confirmed cases. Thurston County has 14 with 0 deaths. And the Washington state doubling is 5.8 days, so more consistent with the curve that's reported for the doubling about every 6 days. New York, as I mentioned, their curve is much steeper, which is why the PPE got directed to them. So I'll go ahead and go to the next slide. I will just go over testing criteria. Again, we have to ration these. So this is the priority. This is standard Washington State Department of Health guidelines. I do think it's important to know that we really need to ask what the patient does for their occupation. So I can tell you that I've sent multiple employees to be tested, and including a physical therapist and a CNA, and they did not get tested because they were, quote, young and healthy. And they are healthcare workers, and healthcare workers are high risk. And so even if they're young and healthy, you need to test those patients if you have testing available. So making sure that you're really asking what their occupation is super important as part of their social history, because they are going to significantly contribute, particularly if they work in long-term care or congregate facilities, to the spread of this illness. Go to the next slide. Okay, so I have a couple questions here. Dr. Ranke, AHA still recommends using ACE and ARBs for heart disease with COVID. Very good. And then Andy Minista, any recommendations for corticosteroid injections for the knee and hip, epidurals for spinal stenosis? So Andy, I will go ahead and look into those. Obviously, if somebody has COVID, you're not going to be injecting those, but I imagine your question is more, should we hold off on those for now, knowing that we're in a pandemic, in case those patients were to get sick after they got the injection? And let me look into any data on if we should be holding off on those. So thank you, good questions. And thank you, Curtis, for weighing in on the AHA rep. I do want to highlight this. This is also DOH on the DOH website, but these are WHO guidelines for specialized droplet precautions. So initially there were practices that didn't want to do the testing because they felt like they needed an N95. I will note that a nasopharyngeal swab is not considered to be an aerosolizing procedure. Excuse me, certainly there are clinicians that feel more comfortable using an N95, but we don't want the lack of an N95 to be a barrier to testing. So it's recommended that you have the patient wear a face mask, their nose exposed, do the nasopharyngeal swab. As a reminder, the nasopharyngeal swab has to go halfway between the nair and the ear. So you have to go back further than you think, and you need to twist it around. For those of you who are delegating this to your MAs and your nurses, make sure that they have been properly trained, because we do not want false negative results as a result of inadequate specimens. So, so again, you do not need an N95 for that. You need a face shield, you need a mask, you need a gown, gloves, of course, and then ask the patient to mask if you can, if you have the PPE. I will put on as a qualifier though, if you have the patient using a nebulizer and they're COVID positive, that is considered an aerosolizing procedure. You need to have an N95. Along the lines that I mentioned earlier with shortages, we are seeing shortages of MDIs as a result of this as well, because people are trying to stockpile them, including hospitals, recognizing that they are wanting their COVID positive patients to use an MDI in lieu of nebulizers. So for those of you who are managing your chronic asthmatics, you may see that there is a shortage in the MDIs available. They may not be able to get their 90-day supply, et cetera. So go ahead and go to the next slide. So I did want to mention a couple symptom checkers. So the CDC has the symptom checker up and running. I believe that launched either Sunday or Monday. So a patient can just go there. They can fill out all their information. It'll tell them whether, through a triage process with all the evidence-based questions, of course, on whether they should proceed with testing. Some limitations of that. Doesn't necessarily have local resources. But it will tell them that they need to contact their health provider for testing. The other thing that I'll mention is the Innovator tool. Sorry, I don't have COVID, I promise. I just got a tickle in my throat. There's a provider-facing app made by Innovator. Those of you who are engaged in PSW are aware of that. So I actually trialed it today, and it's pretty cool. So for those of you who want to do telehealth, if you access via the browser the COVID-assistant and innovator.com, you can go there and actually send the link right to the patient, and then you can do a live synchronous video right there with the patient. So for those of you who aren't comfortable using FaceTime, don't have it, you're sitting in your office and you have email right there, it's super easy for the patient, and it's agnostic no matter what browser they're using. So again, about an hour ago, I tested this just to see how it would work with a patient, and it worked very, very well. So we know that CMS has lifted the guidelines for synchronous video, and we'll get into that a little bit later in the presentation. But some of the commercial payers have not, including some of the Medicare Advantage payers. I just looked at Optum today. They have not lifted that. They still require you to use a synchronous video app. So this is a great tool to be able to do that. So I just wanted to make sure and let you guys know. And clearly, you guys can all contact us offline, and we can talk with you about how to implement this in your offices if you're interested. So, all right, so go to the next slide. All right. So I had some questions there, and I will definitely look into a couple that I wasn't able to answer. And I think that there was some information on patient resources. And so if the executive team there in the boardroom wants me to weigh in on that, I can when we get to that. Otherwise, I'll go ahead and turn it over.
Great. Thank you, Jessica. Are there any questions of anyone that wants to unmute their phone and ask before we scoot on the topics? Okay. Then we're going to move on to PPE supply support, and I'll introduce Carrie Wessel.
Hello. Well, thank you very much. I will try and make this pretty quick. As we all know, PPE is in short supply right now, and that is for everybody basically in the country and the world. So right now, PSW has set up an interim supply room here in the main office. We do have barrier gowns available for delivery. These are linens that will be processed on a weekly basis. There will be instructions on how to access those. An email did go out on Monday with that. You may not have seen it. If you have interest, please let me know after this. We are actively accepting donations, and those are being supplied to our frontline providers. So right now we do have a small stock of N95 surgical masks in stock, and
whoever just joined, if you could mute.
And I have donations of hand sanitizer coming in as well. So we are putting those donations on the provider portal. To request those, just simply send me an email. That is populated there now, and we will update the supply list as the supplies change and they come in. We are also exploring our ability to partner with MultiCare supply chain to access their supply allocations. Now, of course, they're battling their own supply issues, but we will partner with them as we can to gain access, and this could change at any time. They could come in and take all of the supplies.
Yeah, I just wanted to make a comment that FEMA has been requiring to turn over supplies that's been stockpiled by health systems and provider groups. So yeah, there's sort of been, a mad dash to get as much supply as you can, and now the FEMA is saying we'll take your supplies that you ordered or intercept the supply that you've already submitted.
Right, from the manufacturer.
Yeah.
I have checked with a few manufacturers. We do have 34 practices that currently are contracted with, say, McKesson, and they do have a set allocation there that is available. Again, that could change, but that is something that's there. Again, this is on the barrier gowns. To submit or order requests, we can deliver. You can pick them up. Again, there's some instruction there. It's on the provider portal, and just reach out to me, and I'm happy to work with you, your staff, to get you these items. Supply chain allocation, again, just to emphasize this, you're only going to have an allocation if you have a consistent usage. That's how that works. New account orders are not being accepted, so PSW cannot create an account with a supply chain and get supplies for the group. That's not an option at this time. And orders that exceed your established allocations will be automatically canceled. Again, you may already know this. If you don't, please talk to the people who do manage your supplies. If you don't know if you have established allocations and if you need any help with that, please reach out to us. We're happy to help and distribute down to who can utilize that stock. I just said this again. So again, if you don't have the bandwidth, reach out. I managed hospital supply chain for the better part of a decade. Happy to assist in this in any way possible. So just reach out to me at any time. Great. Any questions there? No?
Thanks, Carrie. Yeah. Any hand raising in the chat? No? Okay. If you have any additional questions, Carrie is there to help. And we want to obviously connect some of the resources that would be valuable. So the next thing that we're going to talk about, I'm going to turn it over to Tamara and Cheryl, but I just wanted to share that in the beginning comments about the importance of PSW and population health and how we can help, is that one of the things that we have access to, both for our Medicare Advantage and our ACO lives, as well as other contracts that we manage through the Accountable Community of Health and other contracts through PEB and SEB, et cetera, that we have the opportunity to understand the risk profile of the patients and make sure that I think why we know what's going on right now, which is patients aren't going to the ER and they're not going to the hospital and they're doing a lot of self-managing at home. And we have the ability to identify patients that are at higher risk or patients with comorbidities to determine what we can do to help them be safer and healthier in their homes rather than be in the healthcare system where they're not, frankly, welcome or wanted right now because of the coronavirus and the inability to prepare for managing all those patients in the system, as well as the PPE and other considerations anticipating a surge. So I'm going to turn it over to Tamara and Cheryl to talk through some of the strategies that we've been putting into place as we've been engaging with patients every day to try to help with the delivery and provision of care in their homes. So Tamara?
I think I'm going to go ahead and let Cheryl talk this slide. Unless you want me to, Cheryl, I'm more than happy to. So we're using Innovator, and it's allowing us to identify the ACO lives that we have that are at risk. And Melanie sort of went through this with you. Innovator came up with some dashboards specific to COVID. One of them was for patients who were actually identified to have COVID or patients who were highly likely to have COVID.
And really quickly, just to make sure for those that aren't familiar with Innovator, it takes all of the claims data for every single one of those patients that we have in our risk pool, and it allows us to identify what their disease burden is and what their risk factors are and how many times they've been to the hospital and what kind of comorbidities they have, and are they a diabetic, do they have CHF, all the different components. In addition, we have 3 of our large independent primary care practices that are connected to their claims, their clinical data. So if they're a part of eClinicalWorks, every day we get twice a day a feed of the clinical data into the population health system. That allows us to know whether they've tested for somebody and or if somebody is positive, so that we know that will trigger a certain activities in the data set.
So, and I apologize for that. That's our population health tool. I'm used to talking to the board and not this full population of people on the phone, so I forget that you do not know about our tool. So it's our population health tool. We are dumping all of our data for our ACO into it, including all of our claims data and, as Melanie said, the clinical data for 3 of our large clinics. And so these Innovator worked over the weekend, generating these dashboards that would allow us to identify some of our high-risk patients so that we could move the needle with them and try to save some lives and work to keep them out of the medical infrastructure as much as possible. So do you want me to go through this whole slide?
You're done.
Okay. The next, can we go to the next slide? So this is one of the dashboards, and I'll just sort of walk you through it really quickly. So the top section is talking about the confirmed cases, those who are very likely to have COVID, and that's based upon 3 diagnostic conditions that the CDC has put out there, and those likely to have COVID. So very likely and likely, and you'll note that in our next generation ACO population,
I would assume you want me to not have you listen to this?
What?
Go ahead. Okay, sorry, we're muting. Go ahead, Tamara.
We have 7 patients who are falling into those categories, and so Cheryl's doing outreach. We're able to actually identify whether those are coming from claims or clinical data. You can see that in the pie where it shows 71% are coming from the clinical data and 29% from claims, and that would be because clinical data is quicker and more real-time versus claims data lags. We also are able to look at information on where those are coming from. You can see sort of at the bottom left, you can see the physicians that have the patients that are very likely. Green, again, is likely, not very likely. And so this has been helpful. Cheryl's done outreach to these patients. I'll let her tell you more about that. So can you go to the next slide? This slide is our high-risk members, and actually with the population that we're working with, we have about 13,000 total high risk, and of course that's just due to our demographic of our patient and the fact that you guys do a fantastic job with your diagnostic coding. So this is all based on the comorbidities that have been identified via ICD-10s by CDC. And what has happened here is we've actually filtered out. So the number of high-risk patients we're showing are 271, and that is due to us looking at only patients who have 4 or more comorbidities at one time. If you notice the attribution status, it says 100%. The reason for that is that we only have a single contract in our platform. It's the ACO contract. We also can filter by age bucket. So we have filtered out anyone under the age of 65. We're only showing 65 and older. And it will also show you by zip code where those patients are located. So, you know, we are working with our Lewiston, Idaho folks, and you'll see that the very top zip code is from Lewiston, Idaho. And so we can reach out to them and have them do some work on their patient base as well. It's also, the set of patients is based upon our last attribution month in February. So I am going to be done now, and we can switch to the next slide and let Cheryl start telling the story.
Hi, good evening, everyone. Just to fill you in on some things that care management is doing to help support your patients. And so if you have anybody that you're seeing that you want to refer to care management, you think could benefit from these support services, please let us know. So from our care management support, we're doing remote patient monitoring for increased monitoring needs at home for those risk patients. For food insecurities, right now we're doing an outreach to all those people that we're identifying on the dashboard that Tamara just showed you. And we're evaluating whether or not they're able to get the food that they need. And if they are needing assistance, then we're going to be providing up to $200 for a 14-day supply of food. And that also includes pet food and supplies. We know how important that pets can be to our population, especially during these times when they are staying home and staying away from people, how important pets are. So we want to make sure that we're supporting them. And then also we're making sure that our folks are able to get to their medications. So we're using resources to help assist with identifying local pharmacies that are providing free delivery services. If the service is not free and it's their local pharmacy and we're not able to get to use the free delivery, we will be paying for the services to get the delivery of the medications to them. We're also teaching them on availability of mail order pharmacy. You can proceed to the next slide. So this is just an example of the resources that we're referring our population to. Walgreens and CVS, they're offering the free next day delivery. Rite Aid and Fred Meyer are also doing free delivery. And then the frontline pharmacists, they have limited access and utility of PPE. So we're encouraging patients to take advantage of all these delivery options. We also want them to limit their outings. So we're really trying to promote them to do the delivery for that reason as well. And then Safeway and Hagen grocery stores are also offering senior hours for them to go in. So for remote patient monitoring on your panel, just so you know what's available, there is oxygen saturation equipment for monitoring. We can also monitor their blood pressure and pulse. And there is scales for them to do daily weights if they have other factors which you want to have that monitored. They do not come with thermometers, and so we're asking during our phone calls if the beneficiaries have their own thermometers and to encourage them to take their temperatures. So if you have somebody you want to have more assessment and review of how they're doing, then remote patient monitoring might be something that you want to refer to us for. So, and then for referring patients to care management, we are looking at those who are high risk for COVID, and if you want to refer any of your patients to us for increased monitoring, we're happy to follow them. Also, we're looking at people with increased risk related to multiple comorbidities, including respiratory and cardiac conditions. So again, if you have anybody that you would like us to reach out to on a more frequent basis, we're happy to do that. And then also we're looking to reduce the risks of patients needing to enter the emergency room for potential exposure. So we're doing a lot of education surrounding signs and symptoms to look for worsening condition in their current chronic diseases. And then again, making sure that they have the medications that they need to manage their conditions so that they're not needing to go out. Okay, next slide.
Cheryl, sorry, would I be able to interject? We've had a couple questions come in that are relevant to this, including from Dr. Renke on Dispatch Health and if they are still operating at their full capacity. So I just wanted to weigh in a little bit on Dispatch Health, that they are still operating at full capacity. Additionally, and they are working with PSW on evaluation of social determinants of health. They are distributing meals when they identify that when they go into the home that some of their elders are not able to get to the grocery store. So they're arranging that. They're also distributing hand sanitizer. I will tell you that at this time, Dispatch Health is not offering COVID testing. So I think that that's really important. You cannot deploy them for COVID testing. And I do not know if that's anticipated to change. I did also want to briefly follow up on Andy's question regarding arthritis. I also put it on the chat there for you guys to see. So I just quickly got on PubMed and looked for any data. There is none. So I did go to an advocacy website for arthritis patients. They say that your doctor should only start steroid tabs or do injections if there are no other options for your condition. Additionally, I found another website on the East Coast from Newport Orthopedic Institute. No evidence to suggest that corticosteroid injections result in a substantial increase in risk of infection for COVID-19. However, clearly, as we know, in the weeks following an injection, your immune system could be lower. So if you were to get COVID-19 and recently have an injection, then you could be at higher risk that goes for any infection. So I think just obviously highlighting risk benefits alternatives, consider whether it's worthwhile to add it to your consent form for the time being so patients are fully informed. And then I'll keep a lookout as data is rolling through for specifically that question and definitely follow up with the group if they have any published studies.
Great, thank you, Dr. Van Fleet-Green, for that. So who is eligible, which of your patients would be eligible for our social determinants of health services, which would include the $200 in the groceries, would be people who are have limited financial resources, we're trying to find those who have limited transportation resources to make sure that they're getting what they need, and also those who are high risk related to the need to self-isolate, which is pretty much our population. So if you have anybody that you'd like to refer to care management that you think would be a good candidate for us to do outreach, I've provided our phone number there. And then also you can email us at careteam@pswipa.com, and we are available Monday through Friday from 9 a.m. to 5 p.m. So we'll be checking our phone as well as the email. And I think that's all oh, and then there is a flyer that we're providing to the patients regarding our services, regarding telehealth, and we're also, when we're providing our outreach to our population, we're also identifying whether or not they're aware that any of the providers that are doing telehealth services, that they're aware of that, so in case they need to contact their provider, and then also looking at potentially supporting them so that they know how to use telehealth services and they have the equipment to be able to do that. We're also evaluating, again, for the remote patient monitoring and then nutritional support, medication management, and pet assistance. So we want to make sure our population is aware of the things that we're providing for them in case they need that. On the back of the form is going to be the resources that are available in the community to help them. Okay. And then I'm going to turn over the telehealth resources over back to Dr. Van Fleet-Green. You want to talk about that?
Sure, I can talk about that. So MultiCare Virtual Health, as some of you may know, probably 3 or 4 weeks ago came out and offered free telehealth visits. They were kind of the front of the curve on that before it was being widely advertised. They quickly hit capacity. They typically would do anywhere between 60 and 80 visits a day. As of 2 weeks ago, Friday, they were at over 680 visits in a day. So they had a very quick ramp up. So initially, probably a week and a half ago, when we talked about virtual capabilities for our PSW patients, they weren't fully ready to do that, but we just got notification within the last 48 hours that they are up and running, and they are opening up their services to PSW. For those of you who do not have the capabilities to do that, want to refer your patients up there for telehealth visits, including triage for testing. Please use that as a resource. They're offering waived copays and that sort of thing for patients with COVID, and can also direct them to testing sites. I will tell you that I have also directed several patients to the Indigo clinics, and they have been very responsive, again, particularly for my healthcare workers in facilitating testing. They do use the University of Washington lab. And then for the Medicare Advantage partners, following the Medicare waiver guidelines. So hopefully all of you guys got the memo. I know that I've spoken with many of you about how do we bill for these visits, how do we operationalize this within our clinics. So you can use FaceTime, you can use Skype. All of the HIPAA information has been waived. It does have to be a video visit. However, you cannot do a telephone visit for that. You bill it just like you would do an office visit, but your site of service code, in lieu of being an 11, would be a 02. So hopefully that makes sense. And again, for those of you who have questions, feel free to put it in the chat, and I am answering as we're going along. You can also just send me a text or call me, and I can work through that with you. And I know, Dr. Goen, if you want to weigh in, I know you have been doing this a little bit with your patients. You've had some success with some, and others that have more technical capability issues. It's been a little bit more of a challenge. So I don't know if you want to weigh in.
Well, just to say, I hope you can hear me, that
Yes.
One of our advantages is that Melanie is in the ear of Seema Verma and others at the federal level. And as you've probably experienced, the fact that the person has a compatible FaceTime, but they just can't hit the button and make the video part work, turns a transition of care visit into a $14 phone call. And so hopefully we'll get some headway at the feds and let just telephone conversations become a part of the telehealth waived billing. But it's shocking to me how few people can actually make the connection when we're trying to do these visits.
I had that experience myself, and maybe Melanie can weigh in.
Jessica? Oh. This is Dr. Bunn.
Yes. Yeah, please.
Okay. So I 50% of my patients this morning were telehealth, and 2 of them were Medicare patients. And so what happened was we're using the doxy.me site, and it's been actually incredibly easy because we send a link, they open up their email, and 2 of my patients did not know how to figure out how to turn on the audio, but I could see them. So what I did was I had my computer, and then I had my my iPad with the video, and then I called them on their home phone. So I had 3 ways to do it, and so it was a legitimate video visit. So that's a way to get around that. Anyways, I just wanted to type in about that.
Yeah, that's excellent. Yeah, I have a couple other practices that called me that are using doxy.me. They have also had a lot of success with that. So that's a good one in addition to the Innovator tool that we use, and then your Skype and your FaceTime. I know I'm using the Hangouts, Google Hangouts Meet. I haven't had to do it yet, but I had one of my rounding partners do that who has a cold, and I won't let him in the building. So so we are finding success in that. And then I will comment, and maybe someone on the exec team can weigh in on the Humana permitting the phone call. Can you bill that as a regular office visit, like the video?
This is Melanie. So yeah, you can. Humana, we had a conversation with Humana executives, and as they worked through their interpretation of the waiver requirements, by way of reminder, the waiver, which I'm going to show you on the next slide, that is directly from the toolkit, took away the rural requirement, the synchronicity visit HIPAA requirement, and allowed us to bill for the visits. I think there was a question in the chat box about if you can't take a blood pressure or a vital. I was involved in a conversation today that CMS fiscal intermediary, the Noridian, I think is who you use around here, is that they provided guidance that you just documented that wasn't able to be completed and that they wouldn't audit on the findings. We are asking CMS to provide better clarity and guidance around things that you would do in the annual wellness visit that would require a check. We do feel like as we're deploying remote patient monitoring that you can use that detail to fill in if you are end up doing annual wellness visits via remote patient monitoring tools. Humana is saying it's okay if you can't do the video, which would be helpful for some that won't allow. Dr. Bunn, thanks for your comment on that. There's a lot of different tools, including the one that's in Innovator that allows them to just click on the link. But there's still going to be patients that are still just going to want to call them on the phone. And we want to make sure that we have an opportunity to allow you to bill for that beyond the $14 check-in. And then I'm going to talk about the commercial plans on another slide. So I think we've provided some additional resources related to commercial plans interpretation of the telehealth waivers. And Sarah, do we have another chat question?
Yeah, okay. There's a couple more about, do they have to be established patients if it is a video or telehealth visit?
So go to the next slide. So you don't, to the extent that the 1135 waiver requires established relationship, HHS will not conduct audits to ensure prior relationship existed for claims during the public health emergency. That's directly from CMS's telehealth resources. This is just the one-page grid that is otherwise found in a 7-page link that's on the PSW website that outlines the details around this. Now, just today, we're writing our letter to the policymakers around freeing up the video conferencing capabilities, but also clarifying, because right now these visits are not going to work for patient attribution, HCC coding, clinical gap closures, and all the other components that are required. So we're working very closely with CMS to allow these telehealth visits to count towards the normal billing and visit codes as it relates to managing patient populations. So more to come on that. I feel encouraged about that, but I will share that we are asking for them to turn that, to the extent the waiver requires prior patients to be turned into more formal than an interpretive guideline. So more to come on that. One Health Port is the sort of HIE component, but one of the things that I wanted to share with you around how they're mobilizing under the COVID is to really provide the opportunity for organizations to access how are commercial plans interpreting the guidelines and how would you bill for COVID-related activities. So we talk about Medicare and Medicare Advantage, the telehealth interpretation. I wanted to ensure that even though we're not managing the commercial patients for you, we wanted to make sure that we provided a resource for you to access how to leverage. All the payers have aggregated their FAQ on how to manage the COVID, and that's in one document on our website. So I just wanted to share with you that those I'm sitting on the Administration for Provider Practices distribution group, and then we'll post all the latest and greatest on the website for your reference. Okay, any other? Oh, the other piece is that you can absolutely waive copays. So I know that cash flow is an issue. There might be a way to recoup the copays. I'm going to talk a little bit about that as we look at some of the economic stimulus packages and how we're writing in primary care and independent physician specialists as well in the opportunity to go after some of those funds to help stabilize the income, practice income. So Sarah, were there any other questions we didn't answer?
There was just a comment by Dr. Minister that said that many patients have their own thermometers and BP cuffs and they can tell you their vitals during the telehealth visit.
Yes, perfect. Thank you, Andy. Dr. Minister. Okay, great. So we're going to walk through, and I do want to encourage, I know there were some that were late to get on the call as we are able to observe who comes in and out. At the end, we'd like to re-show the slides on the accessing the website, because that's where all of the materials are, and we are keeping them updated. And then I did get a comment that we also know that Costco has senior-only hours, and so as we build our resources, we'll make sure to constantly update those as changes occur. So there were the first passage of a Preparedness and Response Act was March 6th, and that had an $8.3 billion to HHS, state, and some small businesses in order to implement the initial response to the virus. And then there was the Family First Coronavirus Response Act, which is really aimed at providing sick leave and coronavirus testing, expands some food assistance and unemployment benefits, and expands Medicaid funding. As most of you know, CMS's elective surgery and procedure recommendations were to limit all essential plans, non-essential plan surgeries, including all dental, that stopped sort of from one day to the next. They also extended deadlines for quality reporting programs and all the sort of mechanics that happen with when you're a government programmer. So our quality payment requirements that were due March 31st were moved to April 30th for now. Right now, and pending some signature in the White House is some negotiations around a third legislative package infusing $1.6 trillion aimed at relief for small businesses and industries, including healthcare. It hasn't been signed at the White House yet, but I did want to share with you some good news that we were able to put physicians in the package, not just hospital systems. So that will allow, and I have a Q&A that will come out, and I will share with you as the details unfold, but it allows us to have the physicians actually apply for the relief. And so I want to do a hand-over-hand support and assistance for the providers to help stabilize economics by able to get some of the data. It also includes, for those that are inpatient, paying a 20% additional add-on and then not collecting any sequestration from now until the end of the year. So Medicare is also committing to paying the cash on hand out quicker so that you're able to stabilize some of the cash flow. So, and if you just came on or started moving around, if you could mute your phone, that would be great. Next package, or next slide. Okay, so Medicaid approved the 1135 waiver on March 13th. That is really the ability to expedite and apply on the emergency declaration to expand telehealth to the state, provide administrative emergency relief, and then really suspend some of the normal workflows like prior authorizations, the timeliness for appeals and hearings, and it allows there to more quickly enroll providers, that's supposed to say, and also allows out-of-state providers to bill Medicaid. So if you brought in physicians from another market, they could do that. The real purpose is to provide more coverage more swiftly. The OIC commissioner went on record this morning around the ability to expand access. That is via the waiver. The 1135 waiver is really not dollars as much as removing some of the policy red tape to expand access. The 1115 waiver has dollars, and I'm working out a way that we can maybe leverage some of those state funds that get federal matches to manage with COVID. But that will be for another day. We do want to expand the range of communication methods for telehealth. We want to allow licensed non-physicians to bill for telehealth. On the ACO front, we want to make sure that we're able to have those visits impact ACO attribution and risk adjustment and gap closure. And we want to modify and loosen up some of the remote patient monitoring regulations. We are able to deploy a lot of these services because we are an ACO. If you were just managing Medicare patients on a fee-for-service basis, some of those activities and social determinants of health and remote patient monitoring you would not be able to do. So this is sort of a case for taking a subcap or a risk with a payer, allows us to be more creative and adaptive in times like today. So there's some emergency funding for low interest loans designed for physician groups. We have all these things posted on our website. If you have an individual question, we're happy to help you with our business office. We would love to help you with any of those components. And then again, the interim payments and trying to get some of the payments expedited to your office. We're very concerned about how practices are working so hard to manage the community with the priority needs at hand. And I'm afraid that the cash flow won't be proportionate to that. And so I'm very much singing that from the rooftops to CMS around the need to make sure that independent providers are able to access these funds. And so I wanted to let you know that. I'm also requesting, as well as other coalitions and representatives groups that I work on, to delay the direct contracting new models for 2021. No time to focus on that. They don't have all of their final benchmarking models and other components completed, so they're not ready to press go anyway. So this is a good time to say, let's delay that. I'd like to request that the next Gen ACO be extended by 1 year. That seems to be getting some good traction. And then I'm really wanting to make sure that 2020 ends up being a held harmless year for the ACO, so that we would have risk for upside only, not downside, since there's no stability to how this coronavirus is going to fall out into the cost structure. And when you're in value-based care, what we do today matters for 2022 and beyond. So we want to make sure that 2020 doesn't unfairly and unjustly position us, particularly because we're in one of the hot zones, that it doesn't impact us for the future viability of our business model beyond the current 2020. And then the letter that we submitted and we're requesting is independent physician organizations on the front line responding to the pandemic. And again, we're concerned about the disruption of the crisis is having and will continue to have on the healthcare infrastructure. In particular, physician practices who are currently facing debilitating declines in practice revenue or increasing deficits in value-based arrangements. We have sent letters to multiple congressional staff, including ours in the district, and we are working with both Congress and Senate leadership to communicate those letters. I'm signing on behalf. I do have some call to action. We also submitted a press release to talk about how our organization is responding and functioning to meet the needs. I know just this week, Tumwater had an article, Tumwater Family Practice, they were highlighted in the Olympia News around what they were doing, and I think it really showcases that independent practices are rising to the occasion. I know I've heard many stories and worked with Dr. Wilhelm early on how Yelm was preparing. I heard Tammy Bunn say 50% of her care was telehealth today. I know that our specialist practices are implementing telehealth at great vigor, and we've all had to really redesign our daily practices and workflow to be responsive to the COVID virus. I would like to make sure that we're responsive to the policy and financial implications to the best of our abilities to help support, as well as to sort of aggregate data and resources for you. Next slide. That is really, I think, really, we're done with some time to spare. I know everyone's very busy. We were hoping we could get done in an hour and 15 minutes. I've got 6 minutes left. And if we could go back to the very first slide on the website, that is our holy grail of information with the latest and greatest. And Dr. Goen, I'm going to let him maybe round us off with a few comments and answer any questions. But we did want to have the opportunity to recognize that as a independent physician association, we have the opportunity and ability to help ourselves in a more personal and connected way than other systems and other communities. And so we wanted to sort of set up a Facebook group chat, and the fact that I think we're really here to help each other, and some of the dialogue and some of the questions and some of the resources that you need or want to bounce something off of someone, that we want to be able to be really responsive to what it is that you need. If we didn't cover something you wanted us to cover this evening, we'd love to be made aware of that. If you could call or text or email us, we can provide this as often or as infrequent as needed, and maybe use the website as our primary means of communication. But we want to share ideas and resources and have opportunity to meet your needs. From a policy perspective, I'm going to send some call to actions. I sent some to the board today, but I would like to engage a wider group as we work through these issues together that are unprecedented and really challenging for everybody. So Dr. Goen, I'll turn it over to you for any comments and see if we have any other questions.
Great.
Gary, do you want me to weigh in really?
Oh, sure. Jessica, you could finish that response I texted you.
Gary and I are just dialoguing on places you can get tests, so I'll just run through the list really quick. So the Indigo Urgent Cares are offering tests. The Providence Urgent Cares or Immediate Cares, Hawks Prairie, they now have a drive-through testing site. There is still pretty strict standards. They also offer testing at their Immediate Cares at Hawks Prairie and on College Street only. Additionally, Capital Medical Center is opening up a drive-through that is only for Capital Medical Center physician patients. And then there is a Tumwater Family Practice for their own patients, Yelm Family Medicine for their patients. And I believe that is it. Am I correct on that, team? Did I miss any? Okay.
Well, great.
Hopefully that answered your question.
Maybe just final perspective here. There are a lot of people providing us information from, the AMA, WSMA, CDC, a lot of places you can get information. And I think you're seeing that on this portal, there's a comprehensive resource for you there. So please check on it regularly and if it meets your needs. But also thank you to everyone who is fighting this battle. And your fight may be staying home to avoid exposure. And like some of us, I've pretty much closed my clinic doors and just doing it all by telehealth, and it's a big financial hit. Just keep your spirits up that we'll get through this. And even though we look for the federal government and big systems to solve our problems, every crisis is managed by the boots on the ground. So let's, once again, let's be those heroes in waiting here to get us through this for our community. And thank goodness we have PSW who is supporting us at so many levels. You're represented at the feds, you're represented here locally. So give all the feedback you can that will just help us as a group be interdependent and get through this.
Great, thank you, Dr. Goen. And I did want to share that some of I know like early on, Tumwater had done the parking lot assessment and testing, and I think Pioneer is also providing some testing, and we have the information posted on the website around where you can go to get tested. Like, for example, Capital's going to do that and allow it for their Capital physicians. Kaiser is allowing it, but only for their Kaiser patients. And so as we look at where we can get testing, some of it is, yes, we're open, but we're only going to take our existing population. And I understand there's great reason for that with limited resources. I know that Olympia Multi-Specialty is still seeing patients in the clinic and tele-video conferencing with their patients and doing some outpatient endoscopy and following CDC guidelines. And I know that Ole Ortho is seeing patients and having scribes in managing televisits. And so I know there's quite a bit of work and activity going on, and each organization has built what works for them. I think it might be a good opportunity to share, especially if you need a day off and you're a sole proprietor, you're an independent physician, you might be able to talk to your other sole proprietor around taking a day so that you can combine some of your resources and take a day off, because when you don't have a partner, it's very hard to do that. I know that when we talk about supporting PSW, the command center is the people sitting on the room and on the phone, and it's hard to take a day off when we were talking about how we need to make sure that we do that, and I think part of that is sharing the burden. So maybe our community of providers might be able to find some opportunity to share the burden as well. So any other comments, anything in the text box?
Dr. Rinke mentioned that wound care is still seeing patients at Capitol.
Perfect, great. That's the kind of thing I think is going to be really good for us to keep on the matrix. So we've got that. Please use the website because we're really excited about how much information we're able to keep in there and keep it updated so that it's the latest and greatest. We recognize our emails are inundating with lots of information, so we're trying to make sure it's important enough to put it on there. So we thank you for your time and attention. We thank you for your dedication to the community, and we want to be a resource to you. We only exist because of you. So give us a call or let us know if there's anything that we can do to better support you. And be well.
Thank you. Thank you to the administrative team that's running the show there at PSW.
Great, thank you. Thanks to everybody. Have a good night.